My name is Dr. Kristin Sohl, and I'm a pediatrician specializing in development and behavior at the University of Missouri School of Medicine. Today, I'm going to share with you a new study that we did looking at the Extension for Community Healthcare Outcomes Autism STAT program. We're looking at the diagnostic accuracy of community-based primary care clinicians and how they diagnose autism spectrum disorder. As we think about an intro, I do want to give us a little bit of background on what ECHO Autism is. When we think about the perspective of many individuals who are asking the question of, could autism be going on for a child in their family or in their practice, it's important to remember that there are a lot of perspectives. Specialty care centers are working very hard to apply all of the best practices to the children that are coming to them for answers. Primary care clinicians are engaged with families every day, thinking about the growth and development and all of the anticipatory guidance that goes with primary care. And families are looking for answers. Unfortunately, right now, there are a lot of bottlenecks and a lot of issues that result in long wait times for individuals seeking a diagnosis of autism. ECHO is a project, and it stands for Extension for Community Healthcare Outcomes. One simple way of remembering it is that it's all about moving knowledge and not people. There's a little bit more to it than just that, though. The ECHO model uses technology to leverage scarce resources. In the case of autism, that scarce resources around expertise and how you diagnose autism, what autism looks like across the lifespan. But ECHO is much more than that. We share best practices with professionals in rural and underserved communities around the world. We do this through case-based learning. As our community participants are engaged in bringing their own cases from their own practices, we continue to go through cases and ongoing guided practice as a unit, as a community of practice, if you will. We do this to increase knowledge and access and to help reduce disparities. We think about it as an all teach, all learn model. As a specialist, I'm always learning something from the community clinicians that are sharing their cases with me. And I know that they are learning from our multidisciplinary team as we engage in better understanding what autism and or other developmental disabilities looks like in rural and underserved locations. So ECHO Autism STAT really adheres to autism best practice diagnostic process. We teach a very comprehensive history following the DSM-5 categories, as well as really helping clinicians to ask important and pertinent developmental questions, social family history. We also teach them and they become reliable on a structured behavioral observation, as well as gain clinical expertise over the time that they are participating in ECHO Autism STAT. So the big picture is that ECHO Autism STAT is more than just sitting on Zoom and learning about autism. First, ECHO Autism STAT starts with learning a structured behavioral observation, which in this case is the screening tool for autism in toddlers. But this serves to anchor our clinicians in their learning about autism so that they have a consistent way that they can assess and really reflect on the observations that they're seeing in clinic. But then we don't stop there. Over the next 6 months or so, those ECHO Autism primary care clinicians engage in becoming reliable to a STAT trainer, a certified STAT trainer on the STAT. And they're attending ECHO Autism clinics on a regular basis as they gain additional skills and a better understanding of what autism looks like, and also what autism isn't. Then, after they've achieved that reliability and they've attended ECHO Autism for about 6 months, they're then eligible to present cases to ECHO Autism's expert hub team, as well as their community of peers. So this specific study that I want to tell you about today is an important one. Of course, the background I think is important, and you'll see more of that in the paper itself. But what we did was we took the children that were diagnosed by their primary care clinicians with unambiguous characteristics of autism, and we enrolled them in our study. And you can see here that we ended up with about 20 participants. It's true that these children were all diagnosed with autism by their primary care clinician. Due to limitations in our funding, as well as the structure at the time, we weren't able to expand this to a more robust research method. We did, however, do the best we could by showing and comparing the specialty center processes to what the children had been evaluated with in their community practice. We had an independent of the ECHO Autism process, research reliable psychometricians or psychologists who completed the diagnostic measures that you see here. Certainly, we did all the things that you would expect to be done during a comprehensive visit. 95% of the children diagnosed by their ECHO Autism STAT clinician were also found to have autism by the independent clinicians at the tertiary or regional autism center. On the screen, you can also see some of the measurements that were done and the interesting comparisons. This is just a portion of the same table that you can find in the full paper. We also did a deep dive into caregiver measures and results. 73% of parents preferred receiving care for their child's ASD with a community clinician rather than an autism specialty center. Top barriers that families reported as far as accessing to specialty centers are also listed here. And you can see travel, wait lists, not getting an appointment quickly enough, reliable transportation are all in that top sector. I think it's important for us to think about the opportunity and where we go from here. So currently we have a lot of diagnostic bottlenecks. We have inequitable access for people who live in rural and underserved locations, or who don't have access to transportation, or who don't have access to others who can help them get to an urban or academic center where autism diagnosis currently exists. We also have an extensive resource utilization in our current method. And yet we don't have a lot of great ways of reducing family stress as they're waiting to get answers for their child's development and whether something could be consistent with autism characteristics or not. And we also have very limited community clinician, physician knowledge and self-efficacy. This leads to diagnostic islands. Many children are finding their diagnosis in academic places when they're able to get there. And yet what happens after that? Who is there for that long haul? How do they continue to receive the supports and services over their lifespan as many families report needing? So what are some new directions and some things that we think our study helps us to better understand? And certainly there are opportunities to continue doing a larger scale look at how this could be rolled out across multiple regions and multiple states. But a tiered approach to optimize access, one where we are able to identify unambiguous symptoms of autism in primary care and make the diagnosis in a meaningful way. Those are opportunities for us to reduce those bottlenecks. What about distributed access? Are there opportunities to really partner with interested primary care physicians and clinicians so that we can teach them those clinical expertise and partner across academic institutions into our communities to improve access in an appropriate way so that children have access to what they need when and where they need it? By no means are any of us trying to say that an autism center does not still have a very important place in this system, but we are saying that there is an opportunity here to say, let's do something different so that families have a choice. Families have an opportunity to go to the autism center if that's what they prefer, or to be served in their community by a well-trained and established clinician who can support them both from that diagnosis and beyond. We all know that community professional development for pediatricians, family physicians, nurse practitioners, and many others is severely lacking. There is not training in our medical school system or even in our pediatric residencies related to identifying symptoms of autism and the longitudinal care of individuals on the spectrum. We need to do better, and we can. So community professional engagement and self-efficacy is a new direction. We can look into different ways. And then what would that look like? Are there opportunities to partner with community professionals in longitudinal health homes for children on the autism spectrum? We have a vision, and we hope that you will enjoy reading this paper to really think about how we can do autism and autism supports and services, including screening, assessment, and diagnosis in a different way. In Missouri, we are creating access. We are creating access in rural and underserved locations to really engage and empower community clinicians to do this well, so that our autism centers can thrive and do the research and the critically important work that they continue to do as well. And imagine, what if there was access for those very complex kids? What if those complex kids could actually get access to all of the experts that I know many of you are, and yet the kiddos that are much clearer in their symptomatology could be served more expeditedly and also well. So I thank you for your time. I hope that reading the paper in its entirety will be useful to you. And certainly we are always welcome to answer questions and reach out at any point. Thank you again for your time. I thank the study team and of course, all of the primary care clinicians and their incredible patients and families for their participation in this study.